All right, shock. So at the completion of this lesson, Paramedic Refresher should be able to demonstrate the comprehensive knowledge of cause and pathophysiology into the management of cardiac arrest and peri-arrest states, or pre-arrest states. So demonstrate the a knowledge and pathophysiology into the management of shock, respiratory failure, or arrest, with the emphasis on early interventions to prevent arrest. So shock management. So what is shock? Usually shock involves the hemodynamic instability and the lack of being able to perfuse the tissue. So whenever we're talking about shock in trauma, more likely we're going to be talking about either hypovolemic shock, or we're going to be talking about distributed shock, or otherwise known as cardiogenic shock, because of the fact that maybe the patient just has blunt force trauma to the chest, and you may be looking at dealing with a cardiac contusion, or I just literally had this word in my head 2 seconds ago. I want to call it carditis, but it's not carditis. Basically, where the fluid builds up around the heart. I'm trying to remember the exact word. I literally had it in my mind 2 seconds ago and forgot it. Yes, tamponade. There we go. Thank you so much. So the management of a patient in shock, regardless of the type stage, it is to correct underlying problems if possible and stop or slow down the patient's decline. A paramedic must have exemplary assessment skills to determine that the patient is in shock and immediately correct those life threats that can be corrected and transport without delay. Left unchecked, all patients in shock will die. Just keep that in mind. They will not. I mean, they always say that bleeding stops sometimes, or all bleeding stops eventually. In a lot of cases, when patients are in shock, it's going to stop once the patient runs out of blood. All right. So the adequate perfusion is equated to the movement of blood through the body in the sufficient amount to meet the physiological needs of the body. The Fick principle describes the elements necessary to ensure perfusion, which are enough O2 to load the hemoglobin, cardiac output adequate to move the hemoglobin, respiratory functions adequate to move O2 into the hemoglobin, and tissue receptivity to the offloading of the O2. So the Fick principle, it's saying you need to have enough fluid floating around in the system to carry the O2. The fluid is going to contain a large amount of hemoglobin. Each hemoglobin is able to hold 2 O2 molecules. So you need to have enough fluid in the circulatory system. You need to have a good respiratory system to be able to allow that gas to exchange. You also need to have a nice, good, strong heart to allow it to circulate the blood throughout the system. And you also need to have good tissue perfusion to allow it to offload the gas and return back to the heart. If you have any breakdown in this system, the patient will become hemodynamically unstable. So regardless of the cause or type of shock, the common denominator is the amount of O2 consumed by the cells, or is required by the cells for metabolism. The body attempts to preserve vital signs. So a good example is you have a patient that is losing a large amount of blood. The body tries to compensate by causing vasoconstriction to shrink down the container or the vessels that is allowing to carry the blood, and it's also going to increase the heart rate so it can transport blood a lot quicker around the body. So the less and less blood, the more and more blood that's being lost, the harder it's going to work. It's going to try to constrict it down to its maximum size, to the minimum size, and it's going to try to make the heart work even harder, try to pump even faster until the body cannot keep up no more, and then you start to see symptoms from decompensated shock. So when the body is placed under stress, it will consume O2 more rapidly, and compensatory mechanisms will be activated to restore O2 and required perfusion. So first, the body releases a numerous of neurotransmitters in response to shock. Epinephrine increases the electrical impulse rate and contractibility force of the heart, and increases the musculoskeletal control. Norepinephrine is the vasoperipheral. Norepinephrine acts on the parasympathetic nervous system, and it's going to constrict the vessels, whereas the synthetic nervous system is going to cause the heart to beat harder. The parasympathetic is going to cause it to constrict the peripheral vessels to shrink down in size, so that makes it less room that the blood needs to transport to, and increases the heart's the contractile force. The angiotensin 2 promotes ADH secretions. The ADH increases absorption by the kidneys. The aldosterone promotes salt and water renal retention. Cortisol increases the blood glucose, suppresses immune and inflammatory responses. The renin will released by the kidneys start to react that produces the angiotensin 2. The angiotensin 2 caused by vasoconstriction to increase preload elevates blood pressure and causes the release of aldosterone. So the aldosterone caused by the kidneys to conserve fluid and salt, which increases preload. This can occur within 20 minutes. The hypothalamus gland responds with the release of ADH from the pituitary gland. I know that was probably a lot of information right there. So the ADH is released in the responsive to decrease the blood flow or an increase in the solute concentration in the kidneys. The ADH causes the vasoconstriction and reabsorption of water in the kidneys, which will increase the cardiac preload. So what this is saying here is the ADH has helped increase the size of the container by vasoconstriction, and it sends a signal to the kidneys: do not offload any water. Basically, let it reabsorb, close off the floodgates, and let it just continue circulating throughout the body. These actions are designed specifically to increase blood pressure. The interstitial fluid shifts, move fluid into the extravascular space. So all the fluid that's sitting around in the body, in the capillaries, the skin, it's all going to shunt it into the extravascular space to fill to help fill the voids. So this is a lot of times where your signs of shock comes in. The fluid is all shifted from the, let's just say, from the skin level down into the tissue. It's shifted into the extravascular space. When this happens, it's basically like sucking it dry. And whenever this happens, it squeezes off the sweat glands. So the sweat glands secrete fluid from those, that's just remaining in those glands. And that's why a lot of times your stroke patients become pale and they become diaphoretic. It's because the fact that the blood is shunted away from the capillaries or away from the skin level into the circulatory system, so it can try to promote hemostasis. Okay, this can lead to an increase of vascular volume of 1 liter of fluid per hour. Last, the spleen contains a microcirculation which holds 200 to 300 mLs of blood, which is released into the circulatory system when necessary. During this stage of shock, the neurotransmitters are attempting to support perfusion by increasing cardiac output, vasoconstriction peripheral vessels to maintain organ perfusion, and to provide cells with the needed fuel to meet the challenge. Once the body has released the SNS neurotransmitters, which is the synthetic neurotransmitters, the body has a limited time to respond to it, as resolve the loss of circulation, O2, and then O2 carrying fluid. When the body's baroreceptors first detect a fall in pressure, the body response is the first response is going to be vasoconstriction. So instead of the heart revving up, it's going to try to shrink down the vessel first, or the container first. So therefore, it kind of preserves the heart as a last ditch effort. This occurs in a non-vital organ. So this occurs first by the non-vital organs such as the skin and the gastrointestinal tract. This leads to a increase in PVR, which is peripheral vascular resistance caused by an increase in preload, cardiac output, and eventually a rise in blood pressure. The patient may have a normal BP, but their pulse rate, respiratory rate, skin signs will reflect that they are compensating. The body is in compensated shock, but cannot remain there long. The effects of the compensatory mechanisms cause tissue ischemia, leading to eventual organ damage and then eventually to failure. This stage of shock, if recognized and treated, can be reversed. So this is during the compensated stages. Then eventually, patient starts to go into decompensated. So the decompensated stages is going to be as the compensatory mechanisms fail, metabolism is becoming more anaerobic, producing progressive acidosis. More neurotransmitters are released, caused by profound vasoconstriction. Blood becomes trapped in the capillary beds, that causes the mottling effect and cyanosis. Cardiac output falls due to decrease in preloads, but a further increase in rate. As shock progresses, the cardiac rate will begin to fall. The patient's level of consciousness is going to become altered. Urinary output is going to decrease or maybe absent altogether. Most adults produce about 30 to 40 mLs of urine an hour. At this time, whenever the patient's starting to develop in the shock like this, like I said, the kidney is shut off all access to the bladder. So therefore, it's just keeping the fluid into the circulatory system. Your body's going to stop producing urine altogether. Then we got irreversible shock. This is when the patient declines further and noticeable you don't have noticeable signs symptoms. Tachycardia eventually leads to bradycardia. So the heart is now giving up. It's starting to get exhausted and it's tired of trying to keep up. Skin signs such as mottling, cyanosis, diaphoresis, cool to the touch, temperatures, severe thirst. You're going to see a delay in capillary refill and also falling in blood pressure. Okay, so cell membrane lyse and then also metabolic acidosis increases. Patient usually is unresponsive with decreased pulse rates. Blood pressure is usually not detected. It's going to be very hard to find a blood pressure on these patients. Respirations may be agonal. Skin becomes very dry. Doesn't matter what kind of shock it is always going to be a failure of the cardio. It's always going to end in a failure of the cardiovascular system to provide perfusion to meet the cellular needs. The most basic intention of emergency medical care is to keep all cells alive. So managing a patient's ABCs were created by the means that meet that fundamental goal. All right, so here's going to be a review of system dysfunctions leading to shock. So glucose and O2 enter the cells for production of ATP. ATP is produced to meet the basic needs of cellular metabolism. If the cycle is complete, 32 to 34 units of ATP is produced. Waste products is going to be the CO2, which is expelled through the respiratory system. The body must create enough ATP to support cellular functions. All right, if the cycle is incomplete and anaerobic metabolism as an anaerobic metabolism, only 2 to 4 units of ATP are produced, and the waste products is not completely expelled from the body in the form of the pyruvic acid. The pyruvic acid creates a metabolic acidosis as the result, as the body tries to successfully rid itself of all rapidly rising acidosis. Shock is classified according to the causes. Is it going to be cardiogenic? Is it going to be a pump failure? Is it going to be a hypovolemic issue? Is it going to be a lack of fluids in the circulatory system? Is it going to be neurogenic? Is that going to be due to something's causing a block in transmitters, and the body's going to become, the contagion going to get extremely big? Is it going to be due to anaphylactic? Is it going to be from the body signals everywhere, release of all the histamines that's going to cause a widespread vasodilation, and eventually, so the white blood cells can go through the circulatory system to attack the invader? Or is it going to be usually to cause a septic from a systemic infection that's now enter the circulatory system and causing a bunch of toxins to start attacking the heart and also the circulatory system? And many also be named according to its mechanisms: cardiogenic, obstructive, hypovolemic, dissociative, and distributive. Cardiogenic shock. So this is the heart's inability to provide adequate circulation to maintain metabolic processes. Most common cause is going to be myocardial injuries from an acute myocardial infarction. Attempts by the body to compensate actually worsens the condition. So whenever somebody's having a acute myocardial infarction, it's starving for oxygen at some point because there's, for some reason, it's going to be an embolus, it's going to be a blood clot. It may even be a spasm. Something's causing the heart not to get enough oxygen. So therefore, the tissue is going to be starting to strain and eventually start showing injury. Well, after injury, it's going to start showing signs of death. So whenever the body tries to correct us to keep this from happening, what it's doing is it's going to work harder. It's going to say, okay, I need to pump harder to basically try to circulate more oxygen or give more oxygen to my tissues. Well, that part of the heart is still suffering, so therefore it's starting to work harder. With the more workload, it's going to cause the injury to get even worse. So therefore, it may have started as one small spot, but eventually it spreads and it gets bigger and bigger until complete death happens. So as blood flow is impaired by the body compensates by increasing rate and contractile forces. The injured heart is unable to respond, and the damage of the injury of the heart increases, and cardiac output further declines. Hypovolemic shock. So hypovolemic shock occurs with the fluid loss of 20 to 25% of its volume. Most common causes is going to be blood loss, but it also can be loss of any fluid that depletes volume: sweat, urine, plasma, and dehydration. So hypovolemic shock isn't just for blood loss. It's also including dehydration. You're not drinking enough fluids. Electrocution injuries can cause hypovolemic shock, because the fact that your body's going to flush out all that dead cells, and it can cause the body to basically flood it all out. Severe burns can cause it, because the fact that you not only are you having a bunch of damaged tissue there, but you also have a lot of fluid that's evaporating off of the body. You can also have it with a simple diabetic patient, a patient maybe in DKA or the hypermolar ketoacidosis. You can actually have a patient that's suffering from this due to his urticaria. He has increased urination, and he can become dehydrated that way too, because he's not able to keep up with his fluid intake. Neurogenic shock. So neurogenic shock is a result of repetitive relative hypovolemia. The loss of neurological control over vessels integrity increases the size of the vascular container. So whereas hypovolemic shock, you have not enough fluid into the circulatory system to be able to perfuse the tissue. This one is sort of the same thing, except it's on the container. It's what it is that your container has gotten just way too large to be able to transport that fluid. So therefore, you do not have enough fluid inside the container to properly perfuse the tissue. Blood pulls in the extremities and reduces preload. So with the container getting too big, it's not able to push it back out of the cardiac output is not strong enough to be able to push that fluid out of the capillaries so it can return to the circulatory system. So therefore, this affects your preload. Because the patient's body does not have the ability to compensate normally, decompensation into a more critical phase of shock occurs more rapidly. Anaphylaxis affects the multi-organ systems with vasodilation. So the integumentary signs are very profound. The constriction of the airway can lead to respiratory arrest, which with an acute onset and can progress very rapidly. A lot of times when a patient's having signs of anaphylactic shock, especially since it's not their first time that they've been exposed to the antigen, what happens is that the body responds even faster. So therefore, you may have had some first insult. You may have had some minor swelling, some hives, itching, maybe some swollen lips. But the next time around, the body is ready for this invader, and it's going to do a full invasion, and it's going to cause massive vasodilation, and it's also going to cause the body to swell due to all the excessive amount of edema, and also with this, you also have an excessive amount of mucus production that can easily clog up the rest, that can actually constrict or even hinder airflow altogether. Septic shock. Septic shock develops as a result of severe infection. The infection becomes a systemic infection that includes the release of toxins that the body eventually cannot contain. Septic shock is the most common cause of MODS. Unfortunately, the subtle onset of symptoms almost guarantees that the infection will have become overwhelming prior to its discovery, making it very difficult to treat. MODS stands for multi-organ dysfunction syndrome. MODS is progressive impairment of two or more organs systems that is caused by uncontrollable inflammatory responses after a severe illness or injury. Failure of the gut is a major factor in development of MODS and allows direct invasion of the body by bacteria, leading to infection and sepsis. Even if the patient is successfully resuscitated at this phase, the prognosis is usually very poor because MODS has a mortality rate of 30 to 80%, or has an 80 to 30% mortality rate, and accounts to 50 to 80% of all ICU deaths. Although the diagnosis for MODS has improved in the last 20 years, the fatality rate has not improved as much. MODS is considered primary and secondary. So a patient can die primarily because of MODS, or they can die secondary to MODS, like with the primary being sepsis. The other complications can be secondary to MODS. Primary is going to be primary injury or damage to the organs caused by ischemia that can be readily identified. Secondary is going to be inflammatory responses to the primary injuries. So sepsis. Sepsis definition is definition of sepsis is the body's systemic response to an infection. Severe sepsis is associated with organ dysfunction, shock with hypotension. Septic shock is sepsis with hypotension following adequate fluid resuscitation with the presence of organ dysfunction, lactic acidosis, and altered mental status. Sepsis is the 10th leading cause of death in the US. Men are more likely to die from sepsis, and African Americans and other non-white males are at a higher risk of death. Risk factors include age, extremes, compromise to the immune system, malnourishment, and long-term antibiotic or steroid usages. Most cases of sepsis occurs in patients hospitalized for other illnesses. Sometimes patients that may go to the hospital for one thing may develop hospital, what they call it, hospital-induced pneumonia or hospital-occurred pneumonia. A lot of times these type of sicknesses are very aggressive and they do not respond very well to antibiotics because they're immune to a lot of different antibiotics out there. So they play, whenever it comes to patients that have been hospitalized for an extended amount of time, the longer you stay in the hospital, the higher the risk you have of developing a disease like that. And usually it does lead to sepsis and can ultimately lead, and if it's left, if they're not able to correct it fast enough, it can actually lead to death. So the incidence of sepsis has dramatically increased in the past 20 years. This is probably the result of aging population in multiple ways, the greater number of patients living longer with chronic diseases. There has also been an increase in invasive procedures which expose patients to infections. There is also a growing number of patients whose sepsis develops a result of chemotherapy, immune system suppression, and also HIV. 20 to 35% of patients with severe sepsis and 40 to 60% of patients with severe septic shock dies within 30 days. Others dies within 6 months due to continuing infections, complications of multiple organ failure, and also other underlying diseases. The majority cases of septic shock is going to usually be caused by bacteria. This makes up 70% of all those cases. The common cause of the common causes of UTIs: infection to the liver, bowel, or gallbladder; cellulitis, or infection to the skin; lungs. Pneumonia is going to be another big one, especially this time of year. Now we're getting to that wet, colder time of year. We're going to start seeing more and more patients that's going to have flu-like symptoms or have a lot more pneumonia cases. Patient may also, which is an overwhelming replication of bacteria in the bloodstream, causing massive infection prior to developing sepsis or even septic shock. So a lot of times these are usually patients that are constantly having exposure to sepsis. You see this a lot of times also in some nursing home patients, especially that are bed confined, that may have a suprapubic catheter in. A lot of times those patients suffer from UTIs very chronically because of the fact that they always have that catheter in, bacteria collects on that catheter and can cause a systemic infection. All right, so sepsis. Usually septic shock appears in 2 stages. First is going to be the hyperdynamic stage. This is going to be characterized by peripheral vasodilation, which is going to cause warm skin caused by the endotoxins that prevent vasoconstriction. So when a patient's suffering from a fever, for one, the body's immune system is going to be ramping up the white blood cells. It's going to also increase the internal temperature to try to burn off the invader. Well, the invader is going to cause vasodilation. It's going to cause all the blood set at the peripheral level. Then the second stage is going to be tachycardia, rapid, shallow breathing. Blood pressure may be normal with a widening pulse pressure. So a lot of times you're going to see patients, they may have a blood pressure of, let's say a good example, it's going to be 110 over 40, 110 over 50. You're going to see that wide pulse pressure because the fact that the body's fighting two things here. It's trying to fight off the invader while also trying to keep hemostasis going. So they may also be present with a bounding peripheral pulses. The second stage, this is going to be the Hypo Dramatic stage. This is recognized by the mottled skin, cool extremities, and the patients who look shocky. These are going to be your late stages of sepsis. These patients, a lot of times, in most of my experience, these patients are usually not very responsive. They may have an altered level of consciousness. Their skin is going to be pale to yellowish color. Very slow pupil response. They may even be hypothermic because of the fact that their body's vasodilation has gotten so bad that they're not able to maintain their body heat no more. Patient's blood pressure may be, they may even have absent or diminished pulses. They can maybe even tachycardic. So they may be, blood pressure may be, my last one that was severe was we had a patient that we arrived on scene. We get there, patient was just basically a zombie. It was just laying there in bed, staring off at the ceiling. We asked what the patient's normal mental status is. They said, oh, he's pretty active. He gets out of bed. He does this. He does that. He talks. He's completely with it and everything. So this was a complete change in the patient. Patient's skin was very pale, was very dry, and was kind of yellowish tinge. O2 sats were about 75%. We put him on high flow O2, non-rebreather. We get him up to the mid-90s. We go ahead and we do our blood pressure check. Blood pressure was 60 over 40. So we go ahead and start an IV in the house, and we start fluid administration. So we get him out of the residence. We move him over to our unit while bolusing him. I think we gave him a total of 400 or 500 mLs of fluid. We reassessed blood pressure. Blood pressure is still exactly the same, 60 over 40. Since the container is so large, it was able to take that entire 500 mLs of fluid without no changes at all. So the next step is we went ahead and started perfusion. We started the administration of norepinephrine. We went ahead and gave him 5 micrograms per minute. By the time we got to the ER, he had a little bit of color back. He's no longer yellowish. He's still not very responsive. And he, like I said, he does have a good temperature. He does have somewhat color. He's more like the palish white color versus the yellow color. But now his blood pressure is 98 over 60. They go ahead, the hospital does some more assessment. He is hypothermic. They go ahead and they do the, I think they call it a bear hugger, where they put the blanket over him, do blow the warm air underneath the blanket to help give him some body heat. And they go ahead and start him on a wide range of antibiotics and then transfer him to the floor. So, like I was saying, with this patient here, I noticed that could not find a blood pressure, or we could not find pulses. He was tachycardic, of course, or EKG monitored. I want to say his heart rate was about 110 to 120. He had altered mental status changes because the fact that he went from being able to walkie-talkie just fine to basically laying there staring at the ceiling. It says here, patients who take inotropic medications or vasopressors may also may not be hypotensive. So vasopressor drug medications that instead of actually working on the heart to increase, these are typically your patients that suffer from chronic, what's the word I'm looking for? Chronic hypotension. A lot of times they'll give them medication that will help constrict the vessels so it can increase preload and improve cardiac output. So the treatment for shock, high concentrations of O2 to maintain SpO2 set greater than 95% or higher. EKG, establish IV access, administer 20 mLs per kilogram fluid bolus after every fluid bolus is done. Reassess lung sounds, making sure that you're not putting the patient into pulmonary edema, or you're basically causing the patient to go into pulmonary edema. Administer more fluids to help try to fill the vascular space. Assess mental status, heart rate, respiratory rate, and blood pressure after fluid boluses. Check blood glucose level. If serum BGL is less than 60, administer glucose IV rapid transport. A lot of times when patients are suffering from a infection, a lot of times initially you may see an increase in blood sugar. Non-diabetics, you may see it go up to 130, 140, 150. Diabetics, it actually may increase to 200 to 250 if it was one that was well controlled. I had a lady I was picking up every single day for hypoglycemia. Well, after the third morning of picking her up in a row, I convinced her to go to the hospital. Said, no ifs, ands, and buts. I really need to get you in there to check, to try it, so we could get you in assessed to figure out why your blood sugar is low every morning. Come to find out, she had a UTI. Whenever a diabetic patient suffers from a UTI, it wreaks havoc on the body, especially their blood sugar. She was having a very high blood sugar at night. She was doing everything normally, and then she was taking extra insulin because she's on the sliding scale. So whenever her caretaker came in the next morning, she was always hypoglycemic. So even sepsis can play a huge role on blood glucose levels. Manage it for all other types of shock. Airway and respiratory support. So you're going to go ahead and give them high flow oxygen. You may need to ventilate or provide pressure. Positive pressure ventilation. Suction. A lot of times that their airways could be full of dry mucus. Or secretion, so therefore you need to keep the airway clear. You don't want them to aspirate. They're already having a hard enough time trying to keep their body in hemostasis, so we don't need to complicate them anymore. Administer high concentrations of oxygen. Control external bleeding if there is any. Provide fluid resuscitation. Do EKG. Administer needle decompressions with the tension pneumo. And also consider the mask or the pass pants, the ones that you put on from the waist down, and you inflate the different sections to push the blood to the core. I don't really know very many services that still carry them, but whenever I was initially going through my EMT program back in 2007, we had to train on them. They smelled like mothballs and dirty feet. They were very disgusting, but we had them there mostly for training purposes. So the maintenance of the most important thing is with fluid resuscitation is going to be the maintenance of blood pressure is very critical in patients in shock. Fluid resuscitation may be needed to be aggressive with 2 large bore IVs established without a delay in transport. A common practice is now to maintain a blood pressure of at least a level that is roughly 75% higher of the patient's normal blood pressure, or at the state of permissive hypotension. To me, I was taught a little older that as long as you have a blood pressure at least 90 systolic, you're golden. Now they're more of they like to base a lot of their blood pressures off of the MAP now. As long as you're keeping your blood pressure, as long as you're keeping a MAP greater than 90, you're happy. But the lowest that they would accept it, which MAP is the means arterial pressure, which the way you figure it out is basically you take your systolic and you find out, you take your systolic, add it to your Yeah, you take your systolic, add it to your diastolic, and divide it by 2. Where is that? Okay. So you want to at least maintain a map at least 80. But if you get your map up to a 90, you're golden. All right, so the number of the body's compensatory mechanisms functions best when the systolic pressure is between 70 to 85 millimeters of hemoglobin. Or no, that's sorry. It's supposed to be millimeters of oh well. So you want to make sure your blood pressure is your systolic blood pressure is between 70 to 85 bare minimum. Attempting to maintain a patient's pressure at a normal level by forcing fluid can worsen the bleed and causing a diluted anemia by adding fluids to an already lowered hemoglobin level. So whenever you're doing fluid resuscitation, be very particular about how much fluid you give. Give your 20 mLs per kilogram fluid bolus. Reassess your patient. Remember, you can make things worse. Whenever you're pushing more fluid, you can dilate the system. You can dilute the system too much that it can actually, and if you increase the blood pressure way too much, you can actually cause the patient to start blowing their clots. That's helping stopping the bleeding. And once this happens, well, the blood may be so diluted that it cannot clot again. So always keep that in mind whenever you're giving your fluid boluses. You do not want to push to have your blood pressure above 100, 120. You want to make sure that you're doing what's best for your patient and trying to maintain at least a blood pressure of 70 to 85. Yes. That's why I was taught was 90, but apparently the slides here is 70 to 85. This the information on the slides are based off that new the newest version of the AAOS book. So each book is a little different. I did all my training with Brady, and Brady always said maintain at least 90 systolic. Apparently AAOS is saying between 75 to 80. 75 to 80 feels a little too low for me. So I would like to, if I can keep a patient's systolic at least 90, I will be happy. Yes, fall back to your local protocols. All right. There we go. All right, so if a peripheral line can't be established, considered an interosseous access, especially when the patient will need a large volume of fluid, like burn patients. All right, so fluid resuscitation fluid, isotonic crystalloids, normal, which is going to consist of your normal saline and your lactated ringers. So these are most commonly used electrolytes concentration compatible with human fluids. LR preferred with hypovolemia due to blood loss. The lactate will assist in buffering metabolic acidosis that develop. All right, so the HBOCS, so the hemoglobin-based oxygen-carrying solutions. Just differs from other fluids that they have the capability of transporting O2. So whereas your isotonic crystalloids, they're basically just a filler. They're going to help fill the vascular space to give you enough fluid to allow good cardiac output so you can circulate what hemoglobin you do have. But they do nothing to help carry red blood cells or hemoglobin themselves. So, but this other fluids, the hemoglobin-based oxygen-carrying solutions, these will help will help carry oxygen. So the hemoglobin is obtained from expired human or bovine blood. The hemoglobin is separated from the red blood cells and filtered to remove the antigens or infectious materials. The hemoglobin is then joined with a chain of polymerization. The fluid is compatible with all blood types, and they do not require typing or cross-matching prior to use. All right, so polyhemy is diverted from human blood, must be refrigerated, and has a shelf life of 1 year. The hemopure is derived from bovine blood, does not require refrigeration, and has a shelf life of 3 years. Okay, so the pneumatic anti-shock garments. So these are those funky pants that you hear up. These will help increase blood pressure above the garments. It slightly increases the systemic vascular resistance. You can use them to immobilize a pelvic fracture, and also possibly lower extremities like bilateral femur fractures. This increases intra-abdominal pressure, so therefore these are contraindicated for patients that are having a bleed in the abdomen. They do increase the systemic vascular resistance through the direct compression of tissue and blood vessels. So this is going to push all the blood from the lower extremities up into the upper half of the body, and it's going to increase the vascular resistance by basically moving all the fluid to the container above the waist, or above the abdomen, I guess you should say. They have very minimal auto-transfusion effects. They provide stabilization of pelvic fractures and bilateral extremity fractures, same as some air splints would. So the indication is going to be for a patient that has hypoperfusion with unstable pelvic or bilateral lower extremity fractures. The possible conditions of decrease systemic vascular resistance not corrected by other means, and as approved by locally, or other conditions characterized by hypoperfusion with hypotension. So here's the contraindications. Patients that are pulmonary edema is the only absolute contraindication. You do not want to use it on patients that are having advanced pregnancies. If you do, you do not. If you are going to administer it to somebody that is pregnant, you do not want to inflate the abdominal compartment. You only want to do the legs. You cannot use it on objects that are impaled in the abdomen or eviscerations. Or you can use it, but you do not want to inflate the abdominal compartment. And patients with chest wounds or uncontrolled bleeding outside of the confines of the pants. Because if you go and push all that blood up into the upper extremities, and he has an internal bleed that you cannot control, all you're doing is basically pushing more blood up there so it can expel faster. Cardiogenic shock. By increasing these, by pushing all the blood up there, you can accidentally increase preload that can adversely make the patient's cardiogenic shock worse. Pulmonary edema it's going to do the same thing. It's going to increase preload, and if you are having a patient that is suffering from congestive heart failure, especially left-sided, it can actually cause their pulmonary edema to get so much worse because it's going to start backing up even more fluid into the pulmonary system, and uncontrolled bleeding outside the confines of the pants. So here's a picture of the pants, what they look like. All right, so pharmacological interventions to consider. For hypovolemic shocks, you want volume expanders and HBOCs or OCSs. Cardiogenic shock, you want a volume expander with some vasopressor. Distributed shock. You want some volume expanders, vasopressor, and you may also want to look at using mass pants or the PAS pants. Obstructive shock. Volume expanders is the only thing you could do for these individuals. And also spinal shock is going to be volume expanders. You know, you want to increase the amount of volume that's inside that container. So consider transport considerations. All these patients get LSD, light sirens, diesels to the most appropriate center, which is more likely going to be your trauma centers or your specialty centers. You may want to consider air medical transport if you have an extended distance, time, or terrain. Where I work at, we're at a very unique geological location. They have come out and said that a air ambulance is, or an air medical transport is really not indicated if you're within 85 miles of a level 1 trauma center. So with that being said, we're right at our level 1 trauma center is 76 miles from our county, from the center of our county. So if we call for a helicopter, we get from scene, helicopter comes to us, they take off with our patient, we can actually get the patient to the hospital within anywhere between 5 to 10 minutes faster than what that helicopter can. If we get on scene, we keep our scene time less than 10 minutes, and we start rapidly transporting to the trauma center. Where it does give us an advantage is if we pre-alert them, have them do a flying standby or automatically dispatch to the scene. We get there as we're getting the patient extricated, or as we're sitting there doing our assessment, helicopter comes and lands. Well, they're landing pretty much within our 10 minutes. We can get them loaded up on the helicopter. Then we do see that 5 to 10. We can see additional 5 to 10 minutes advantage that way. But most of the time, we don't really know 100% what we have on scene unless we have a first responder on scene that can relay information back to us. So we typically ground transport a lot of our patients to our cath labs. Our closest cath lab is 60 miles away, and our closest trauma center is 70 miles or 76 miles away.